Apoorva, we will start.
Ma'am, okay. Ma'am, am I audible, ma'am?
Yeah, you're audible.
Oh, shall I start, ma'am?
Yeah, Apoorva, you can start.
Okay.
Apoorva, you are starting?
Yes, ma'am. Just 1 minute.
Slideshow, you have to keep slideshow.
Yeah, yes. Good evening, everyone. I'm presenting a case of a newborn with invasive fungal infection. Just 1 minute, please. Slides are stuck. A baby X is a male preterm baby born at 27 weeks gestation on 15th August of this year with a birth weight of 900 grams. The baby was shifted to our hospital for respiratory distress and preterm care at 3 hours of life. Coming to antenatal history, it was a booked case with regular antenatal checkups and scans. There was no significant history except for in third trimester at 26 weeks, the mother had preterm premature rupture of membrane for 3 days, but there was no history of any fever or falls in lighter. And in view of severe oligohydramnios at 27 weeks, emergency section was done. Being an outborn baby, we don't know the resuscitation details of occurs. The baby was shifted to our hospital at 3 hours of life. And coming to the course in the hospital, on day 1, at 3 hours of life, the baby had received surfactant, and we had started antibiotics in view of visited PPRI for 3 days. And the baby was in shock, we had started anabolics. Invasive had showed a significant PDA for which IV paracetamol was started, and anesthesia was normal on day 1. On day 3, the baby clinically worsened with septic shock and scleroderma. So we had updated the antibiotics and hyped up the iron foods. And the baby clinically gradually improved, and by day 7, we had weaned off the baby to CPAP. And the UVC, which was inserted on day 1 for anatropes, was removed. And the initial backtick on day 3, it had shown no growth. On day 9, the baby again developed repeated apneas and severe thrombocytopenia. And NSG to go were normal. And in view of extreme premature risk factors like extreme prematurity, presence of endocrine movement, umbilical venous catheter, we had started empirical amphotericin for the baby on day 9. And again, the baby clinically improved, and we had weaned off the baby to CPAP. The backtick had shown candida non-albicans, which is Candida tropicalis, sensitive to amphotericin B fluconazole, and 2D-co was normal on day 12. On day 15, again, the baby developed recurrent apneas and persistent tachycardia. We had to intubate the baby, and the baby was not in hemodynamically stable. Echo had shown a normal ventricular output and normal contractility. But But still the baby had developed recurrent apneas and persistent tachycardia. I think at this point, I would request the audience to put down your DDs in your chat box. So this is a preterm baby, extremely low birth weight, 27-week of baby, with Candida sepsis, which was sensitive to amphotericin B, and we were giving amphotericin B for 5 days. Despite of giving a sensitive antifungal, the baby had deteriorated again on day 15. So I would request everyone to put on your DDs in your chat box, or either you can unmute yourself and tell the DDs.
They have written it as amphotericin B resistant Candida Apoorva. DD. Amphotericin B resistant Candida is one of the answer in the chat box. You want to take it? Could it be amphotericin B resistant Candida?
Yeah, sensitive, but in vitro they had given a sensitive. The organism
But
was
the thing is
sensitive to
that
amphotericin B.
the baby has responded. Like the baby has started to respond once we have given amphotericin B. Then once again the baby has deteriorated. So that could be unlikely. The next somebody has answered it as meningitis.
Yes, meningitis is definitely a possibility.
So whenever you have a baby with apnea, on day 15 of life, we have to think some CNS involvement with this infection. So one is some CNS infection following Candida. They were asking about CSF studies. So one is, it could be a CNS infection spreading from the blood. Other DDs, any other DD, why the baby is having tachycardia in this baby? They're asking any feed intolerance, Apoorva.
No, there was no feed intolerance in this baby.
So will CNS infection cause persistent tachycardia? This baby didn't have abdominal distension or such kind of feeding intolerance. The baby had apneas with persistent tachycardia.
So
what could be the cause for persistent tachycardia? Target organ involvement. Apneic seizures. Yeah, somebody has written thrombus.
Yeah.
So yeah, it could be some systemic manifestation of this fungal infection. SIRS, shock.
Actually, the baby was not in shock at that point of time. Blood pressure was normal, even in the 2D echo. The contractility was good, good for normal cardiac output.
So yeah, Apoorva, you can go ahead.
Yeah. Yes, ma'am. So DDs, we even thought of if PDA might have been opened again. Is a new either a new onset sepsis or a persistent Candida, or meningitis, or metabolic causes like hypoglycemia. I'll just show the projected 2D echo video of this baby. Can you see, ma'am?
Yeah, we can see Apoorva. Yeah.
So does anyone want to comment on this 2D echo?
Some thrombus in the septal vegetations.
Yes, yeah. So as we can see here, there is around we are seeing around 2 into 1.5 mm of vegetation over the interatrial septum, and this could have been the cause of persistent tachycardia for the baby, and so probably because of it, probably it's affecting the underlying AV node. So there have been few case reports of Candida vegetations leading to tachyarrhythmias because of involvement of atrial septum and the AV node. So that would have been the cause of persistent tachycardia in this baby. And if you see the neurosonogram, here you can see echogenic round foci in the left frontal lobe, and you can see multiple micro abscesses in the parietal and occipital lobe, parietal occipital lobe in this baby. So NH neurosonogram had shown multiple ring lesions in the right parietal and left parietal occipital lobe, likely micro abscesses. So the CNS involvement was probably the reason for the baby having recurrent apneic episodes. So we were already giving amphotericin B for this baby, and the initial NSG was normal. So despite of amphotericin B, the baby again developed this microabscesses leading to and worsened clinical condition. So I would like to ask the audience the role of amphotericin B deoxycholate in CNS Candida infection. Do you use deoxycholate amphotericin B in CNS Candida infection, or do you prefer liposomal or any other antifungal in CNS Candida infections in neonates?
So what is the drug of choice whenever there is Candida infection of involving the CNS? Because a few centers we see they are using liposomal amphotericin B. So we want to discuss this point, whether we can use amphotericin B or liposomal amphotericin B or any other drug when this baby is not responding, even though the blood culture is showing sensitive to amphotericin B. So in the chat box, one of them has written as flu cytosine, Apoorva.
Okay, yes, we'll discuss about that. So
Yeah.
this is a slide on antifungal duct penetration in CNS. This is in adults. I'll come to newborns again. The CSF penetration of fluconazole, which is commonly being used in NICUs, it is good 50 to 100% CSF penetration. It also around 70 to 100% brain tissue penetration. When coming to echinocandins, micafungin is most commonly studied drug in NICU babies or preterm babies, which has around 25% of brain tissue penetration, but very low CSF penetration. And clinical success reported with micafungin in CNS infections, no. When coming to amphotericin B deoxycholate, this deoxycholate and even the liposomal amphotericin B, the CSF penetration is poor, but brain tissue penetration is about 27-22%. Flu cytosine has excellent CSF penetration as well as tissue penetration. This is in adults. So when we come to preterm babies, the CSF penetration of amphotericin B in infants, especially in preterms, is higher than in adults, with concentration of 40 to 90% of serum concentrations, and they do have substantial brain tissue penetration. This has been published in Journal of Pediatrics in 1990. So, and they have found that amphotericin B deoxycholate and liposomal amphotericin B, when they compared the both drugs, there are no direct RCTs comparing both the drugs in preterm babies with CNS infections, but both ampho B and also liposomal had similar efficacy in treating CNS infections. But ampho B deoxycholate had there are more studies on amphotericin B deoxycholate than with the liposomal amphotericin B in preterm babies. So what would be the next line of management as this baby deteriorated even on amphotericin B? So in view of CNS involvement and recurrent dyspneas despite 5 days of ampho B, we had started the baby on flu cytosine at a dose of 25 mg per kg per dose 6 RD. And because the baby had endocarditis with vegetation at risk of emboli, we had started a prophylactic enoxaparin. the baby gradually was weaned up to sit up in 17 days of life. And we had scanned for other organ involvement, ultrasound abdomen for liver, spleen, and renal abscesses. Everything was normal. Urine for hunger factor was negative, and even eye examination was normal. CSF analysis was normal for the baby, and we had repeated backpack after 1 week of starting flu cytosine, and it had shown no growth. And amphotericin B and flucytosine, they were continued for 6 weeks. In our baby, NSG had shown clearance of all the macrophages after 3 weeks of therapy, and the 2DCO had shown clearance after 4 weeks of therapy. We had discharged the baby with 15 gram weight at 52 days of life. So this is how we monitored the baby on amphotericin B and flucytosine. So initially on 24 hours of life, everything was normal. At 70 hours, baby had thrombocytopenia with the positive CRP and no growth. And we had repeated when after we started flucytosine and amphotericin B, we had repeated LFTs, RFTs, and CBTs initially alternate day for around 3 to 4 days till they were stabilized. And after that, we had repeated every week till discharge. Due to invasive candidiasis, about 64% of neonates admitted to NICU are colonized by Candida by 1 month of age, either from vertical or by nosocomial transmission. Horizontal transmission being most common reason for the colonization. Vertical transmission, it is more in newborns born by vaginal delivery than by LSCS. The incidence of invasive fungal infections in middle birth weight infants ranges from 1 to 5%, and in extremely low birth weight infants, it can increase up to 10%, and up to 20% invasive infections are seen in infants and born less than 26 weeks of gestation. The incidence of endocarditis reported in 5% of invasive fungal infections, and it had a high mortality rate of over 60%. Even brain abscesses, they are rare, with only incidence of around 4% of invasive infections with a 60% combined morbidity and mortality. And invasive fungal infections, they had a 57% incidence of neurodevelopmental impairment with about 30 to 50% mortality. The 5 Candida species that they account for about 90% of Candida infections in NSMs. About 50%, 50 to 60% is because of Candida albicans. But even the Candida non-albicans infections, they have been on rise since 2 decades, especially Candida glabrata, cruzi, tropicalis, and parasitis. Knowing the exact species is very important for Candida infections, as some of the species are inherently resistant to some antifungal drugs like glabrata and cruzi. Around 30 to 40% of the isolates they are resistant to fluconazole. And Candida parasitis, about 25% of the isolates are resistant to amphotericin B. Candida auris, it has been on rise in some of the NICUs, which is a multi-drug resistant species, sensitive only to echinocandids. Why premature babies are more susceptible to Candida infections? It's because of immature skin barrier, and they don't have vernix gaseosa, which contains antimicrobial properties like peptides, lysozyme, and lactoferrin, and they have an immature adaptive immune response system. So these are some of the risk factors for the Candida invasive fungal infections in NICU. Some are non-modifiable, some are potentially modifiable. More importantly, in potentially modifiable risk factors are central venous line, intubation, presence of AT2, giving broad spectrum antibiotics, giving antacid systemic steroids, and intravenous lipid emulsions. Lipid emulsions, they increase the biofilm formation of the Candida. Coming to pathogenesis, three main mechanisms: the fungal adhesion to the host tissues is of primary importance for colonization, and in the presence of damaged epithelium, it allows more fungal adhesions leading to invasive infection, and the ability to form intraliminal catheter biofilms is one of the pathogenic mechanisms. So coming to the transmission, with our vertical or horizontal transmission, as we have already mentioned, they lead to colonization of the babies, the most commonly on skin, respiratory tract, and GI tract. And in the presence of patient factors, organism factors, and medications, presence of all these risk factors, they can lead to disseminated infection. Infection is candidemia. The candidemia in the presence of other risk factors like immature in preterm babies and in the presence of any valve injury or tissue injury, like the presence of any venous catheters, inherent properties of the fungi, and delayed, if there is a delayed vascular catheter removal, delayed diagnosis, they lead to endocrine dissemination. So infants who are diagnosed with Candida, they should undergo evaluation for the system endocrine involvement. So we need to get cultures of blood, urine, and CSF done, and eye examination for endophthalmitis, echocardiography, and USG of liver, spleen, kidneys, and bladder for presence of abscesses and use of membrane. So the diagnosis of the Candida infections in neonates is difficult. There are only a few diagnostic modalities, the most common being the blood culture. But the sensitivity of the blood culture for diagnosing invasive diseases is roughly around 50%. And the cause for the low yield of blood culture, it has been attributed to few reasons, like there could be only temporary candidemia, and there could be endocrine involvement without the presence of candidemia. And there is evidence that there is an intermittent release of Candida into the bloodstream. So repeating blood cultures, taking multiple blood cultures from different sites is of paramount importance in diagnosing the Candida infections with neonates. And moreover, blood cultures are limited as they have a slow turnaround times, ranging from 7 days to even 30 days in case of some species of Candida, which are slow growing. Even the cultures of the tissues are fluid, like CSF or if you take any aspirate any fluid from the abscesses, they also exhibit poor sensitivity of growing Candida infection. Candida, it's less than 50%. So if there is a central venous catheter, the catheter should be obtained through the catheter and the peripheral vessel to distinguish between disseminated infection and catheter-related candidiasis. And these are the conventional culture media for fungi. The most commonly used being for blood agar and sugar or dextrose agar. These conventional media, they take the turnover time for growing the fungi. It ranges from around 7 days to 30 days, as I already mentioned. So in the recent time, there are automated blood culture systems like BACTEC and BACT alert. So this is a study on direct comparison of BACTEC and BACT alert for detection of the Candida. As you can see, and in this BACTEC and BACT alert, there are 3 media for each system: aerobic, anaerobic, and mycology media. And the both automated blood culture systems detected all episodes of candidemia when specialized mycology media were used. But only if we ask for only aerobic and anaerobic media, then the BACT alert had performed better than the BACTEC in overall growth detection and time growth detection. So whenever we are ordering BACTEC and we are suspecting a fungal infection, we specifically need to ask for a mycology media, not just aerobic media. Mycology media helps in earlier detection of the Candida infections, any fungal infections, with turnaround time of about 25 hours. Coming to other non-culture diagnostic tests like Mannan antigen and anti-Mannan IgG and antibodies. The sensitivity were low, around 58%, 59%. Specificity were around 23%. And this has been extrapolated from children and adults. No major trials that have been done in premature babies. Even in this is one of the meta-analysis done for diagnostic accuracy of serum 1,3-beta-glucan for invasive candidiasis. In this study, they have found higher sensitivity, about 80 to 90% sensitivity. But it is too early to recommend its use. But they have concluded that it is too early to recommend its use because of scarcity of reliable clinical data and heterogeneity of case definitions. So we need more studies on this diagnostic modality before we use routinely for our premature babies. Coming to PCR as a diagnostic modality for candidemia. So this is a recent study published Candy New study published in Journal of Clinical Microbiology 2017, where the sensitivity and specificity of PCR around 87 to 81%, with the high negative predictive value of 98%. Even the beta-glucan sensitivity was 70 to 60% specificity, with a higher negative predictive value. So in this study, they have found a higher negative predictive value and a moderate sensitivity for the PCR and beta-glucans. The problem with the PCR, the limitation of the PCR studies is there is lack of standardized methodology, and even there is no multi-center validation of the assay performance. Coming to treatment, is there a role of empirical antifungal therapy? Yes. So there is an observation study of extremely worthwhile babies with invasive candidiasis who were created NSPHD. It has suggested that empirical antifungal therapy had increased the survival without neurological impairment. The odds ratio 0.27. And coming to the just a short note on the drugs, there are three main classes of antifungals: polyenes, azoles, and calcandins. The mechanism of action of the poly is amphotericin B. It inhibits the ergosterol, leading to formation of the pores in the cell wall, leading to the lysis of the fungus. Azoles, they inhibit the formation of ergosterol, they inhibit the formation of the cell wall synthesis. This is assumed as a fungistatic agent. And echinocandins, they inhibit the formation of the beta-glucan synthetics. So it also leading to pores, increased permeability, and death. Cytosine inhibits the DNA and RNA synthesis. Coming to the CPG guideline for management of candidiasis in 2016 by Infectious Disease Society of America. So these are the recommendations by CPG. Amphotericin B deoxycholate is recommended for neonates with disseminated candidiasis. And fluconazole 12 mg per kg intravenous or oral is reasonable alternative for patients who have not been on fluconazole prophylaxis. And lipid formulation is an alternative, but it should be used with caution, particularly in the presence of lipid involvement, as we know that liposomal amphotericin B does not penetrate well into the ring tissue. And echinocandins is actually a salvage therapy in situations where there is a resistance or toxicity which precludes the use of amphotericin B deoxycholate of fluconazole. Venous catheter is strongly recommended. And the duration for therapy of candidemia without end-organ involvement is around 2 weeks after documented clearance of Candida species from the bloodstream. And for serious infection, the recommendations are for initial treatment, it is amphodeoxycholate. And the alternative regimen is liposomal with a low quality evidence. And the addition of fluconazole, it is considered as salvage therapy in patients who have not had a clinical response to initial amphotericin. And once the patient has responded to initial treatment, then as a step down, fluconazole is recommended for isolates that are susceptible to fluconazole. And the therapy should continue until all the signs, symptoms, CSF, and rheological abnormalities have resolved. If there are any devices like ventricular stimulatory insumption, they have to be removed. This is a flowchart of treatment of invasive candidiasis. In the bloodstream infection, that is only candidemia without any endocrine involvement, we can give either amphobi or liposomal amphobi and treat for 2 weeks starting from the second negative blood culture. For UTI, amphotericin B. Liposomal amphotericin B should not be used for UTI. And for meningitis, start with deoxycholic amphotericin B. And if there is a persistent positive culture even after 5 days of amphotericin B, then you can add 5-flucetazine as a sandwich therapy. If there is an endocrine dissemination, you have to treat for 4 to 6 weeks. So how do we monitor amphotericin B? Alternate day electrolytes, initially every day, alternate day creatinine, and followed by twice weekly. And complete blood count initially twice a week, followed by once a week, and liver enzymes once a week. And monitoring of flucetazine initially daily, complete blood count LFT, RFT, followed by the same investigations twice a week. Just a note on antifungal prophylaxis. So prophylaxis, it prevents invasive fungal infection by decreasing the colonization of the skin, GI, and respiratory tract, as well as central venous catheter. This is the forest plot of the Cochrane database system created in 2015. It's around total of 752 events. It had favor antifungal prophylaxis with a risk ratio of 0.43. So around 57% decrease in the instance of invasive fungal infection after starting the antifungal prophylaxis. When we compared with the systemic antifungal versus placebo or no drug, and the primary outcome being death prior to hospital discharge, it is not statistically significant. In the subgroup analysis of only extremely overweight babies, the systemic antifungal prophylaxis reduced the incidence of invasive fungal infection. And the same, but the effect on mortality was not statistically significant. Coming to CPG guidelines on antifungal prophylaxis, in the nurseries where there is more than 10% of incidence of invasive candidiasis, IV or oral fluconazole prophylaxis, 3 to 6 mg per kg twice a week for 6 weeks. It can be started. They have to be started. It's a strong recommendation. And fluconazole prophylaxis can be given either IV or oral. Oral bioavailability of fluconazole is also very good. It's more than 90%. In case if there is resistance to fluconazole, then you can even start oral nystatin for 6 weeks. And the other prophylaxis for invasive candidiasis is controlled lactoferrin. In 2020 meta-analysis of 6 trials which have included about 3,000 infants, enteral lactoferrin had decreased invasive fungal infection when compared to placebo. The risk ratio of 0.23. But the probiotics, it is controversial in the prevention of the invasive fungal infections in newborns. So, despite the apparent large effect in reducing colonization, the probiotics did not appear to have an impact on reducing the incidence of invasive fungal infection. So, our baby had received about 6 weeks of amphotericin B and flucetazine because there was endocrine dissemination, endocrine involvement. And after 6 weeks, after about 4 weeks, everything got cleared. Radiological clearance was there. And at 6 weeks, we did discharge the baby. And during the course of the antifungals, we did not document any side effects with amphotericin B, deoxycholic, or with flucetazine.
Apoorva, you want to say any take-home message of your presentation?
Yes, ma'am. There are a few take-home messages. One is the efficacy of plain amphotericin B, deoxycholate, and also liposomal amphotericin B is almost similar in invasive management of invasive fungal infections. So, the only recommendation when to use liposomal amphotericin B was if there is a renal involvement. which precludes the use of deoxycholate. Otherwise, we can initially start with deoxycholate amphotericin B. And the second thing, whenever we are ordering Bactec for fungal infections, invasive fungal infections, we have to make sure that we ask for the mycotic media in the Bactec or bacterial water.
Few other points I want to add is like whenever you have a baby with fungal sepsis, other organ involvements have to be frequently monitored. Even though initial neurosonogram 2D echo may be normal, we have seen in our case where the baby has deteriorated. Even though we have started a sensitive antifungal drug, there is a need to follow up these babies with a neurosonogram